Thank you. Thank you, Janko, for your introduction. I would like to thank the organizing committee for giving me this opportunity to participate in this forum as a speaker. These are my disclosures. And I will talk on why we need to expedite the HIV treatment among people living with HIV. And the second, I will talk about the discrepancies observed between clinical trials and observational studies in terms of same-day antiretroviral therapy in the engagement of care after initiation of antiviral therapy. And the third, I will talk on the experience Taiwan have achieved. Before I proceed with my presentation, I would like to refer you to this article just published in Clinical Infectious Diseases. This is an excellent written review article on the treatment initiation. And Dr. Ford will be presenting on the AIDS-related opportunistic infection today's data. As you know that standard care in terms of HIV treatment started from HIV testing. And there will be several steps to follow from testing to ART treatment. There were also several preparatory steps and administrative requirements, as mentioned by Janko, in ART, before ART initiation. All those steps would increase the risk of disengagement from care, particularly in regions with limited access to care. But as Janko mentioned, maybe in resource-rich countries, these barriers remains. But in rapid antiretroviral therapy initiation, if we are able to integrate HIV and STD testing, counseling and education and support with the ART initiation, we could start ART in the same visit. But of course, investment in transformation of HIV care is needed. I believe that there are not much need for us to really debate on the benefits of same-day or rapid ART initiation in terms of the virological or immunological responses to ART, particularly in the era of INSTI-based antiretroviral therapy. These four bullet points really indicate the benefits of rapid or early antiretroviral therapy. Earlier initiation of antiretroviral therapy improved the outcome and prognosis of people living with HIV. Early initiation of antiviral therapy increased the CD4 recovery. And the most importantly, early initiation of antiviral therapy achieve earlier viral suppression, which leads to significant decreases in onward transmission. And of course, early ART initiation were likely to increase the engagement in care. But of course, there are several individual considerations which will be discussed by Dr. Wang later. These two randomized clinical trials, START and TIMPRANO, have demonstrated immediate ART in those with high CD4 count. These reduced the risk of AIDS-related event, non-AIDS-related event, and death or severe bacterial infections. To your left, START study subsequently also revealed that early initiation of antiviral therapy reduced the risk of virus-related or virus unrelated malignancies. And these findings are also subsequently corroborated by observational study. So to your right, the NA-ACCORD observational study revealed that early ART initiation also reduced the malignancy risk, regardless the virus-related or non-virus unrelated. And in this just published paper, the investigator wrapped up 17 clinical trials, randomized clinical trials. They found that delayed ART initiation, that is the ART initiated at the CD4 count less than 200 cells per microliter, and virus load greater than 100,000 copies per mil have a detrimental effect on the biological responses. So those studies suggest that we should start ART as early as possible. But when we will talk about the impact of same-day or rapid ART initiation, there were no randomized clinical trial conducted in developed countries, although we know that there are several randomized clinical trials conducted in resource-limited countries. In this study, in this small cohort study conducted in San Francisco HIV clinics, the participants, of all those participants, 40% of them have mental illnesses or using illicit drugs, and 35% of them were homeless. So this was a typical population. But the investigator aimed to test the impact of rapid treatment on the biological responses and their linkage to care. They found, not surprisingly, from this time point, that rapid ART initiation shortened the time to viral suppression than universal CD4-guided initiation. In terms of linkage to care, because of small sample size, they were not able to demonstrate the better higher linkage to care in those who were put on rapid ART initiation. And similar findings were observed in men who have sex with men who initiate ART immediately after the diagnosis of acute HIV infection in Netherlands. They found that ART initiation immediately after diagnosis had a shortened time to achieve viral suppression than those who put on standard of care. That is the ART initiate when their CD4 count fell below 500 or have acute symptoms. So what would be the benefit in terms of viral suppression by early ART initiation? I think it's very, very clear. If you see on this graph, the black line, the y-axis indicate the time zero of the HIV diagnosis. So there will be a long interval from the diagnosis to viral suppression when the ART initiated later. But if you look at the red line, you move the red line forward. So you shorten the interval between the diagnosis and ART initiation. So you are able to achieve earlier viral suppression. So that the interval will be indicating that you are preventing, you are averting the onward HIV transmission with earlier HIV suppression. As we know that the majority of HIV infection occurred through unprotected sex. So with rapid or same-day ART initiation, the viral load in blood plasma and seminal plasma would decrease by 2 logs or greater after 7 to 14 days of antiretroviral therapy, particularly those regimens containing INSTI. So you can see from this diagram that the viral load in the plasma, blood plasma and seminal plasma decrease simultaneously and very significantly. So in this review of 4 clinical trials before 2020, the same-day ART initiation conducted in Africa and Haiti. Okay. The same-day ART initiation increased the ART start within 90 days of diagnosis and increased the retention rate and the rate of viral suppression. Also, the rapid ART initiation decreased the loss to follow-up and death. So I will show you 2 clinical trials demonstrating that the benefits of rapid ART initiation. So in this rapid trial conducted in South Africa, in 2 clinics in South Africa before the implementation of universal ART treatment and rapid ART initiation. And we have observed that the rapid ART initiation increased the 25% of ART initiation, increased 13% the absolute value, 13% of achieving virus load less than 400 copies per mil, and increased 70% of retention in care. And in this Cascade trial that was conducted in rural Lesotho, investigators conduct HIV testing in around 6,700 households, and 270 people newly diagnosed with HIV infection were randomized to same-day home-based ART or usual care. In the same-day home-based ART initiation, the study participants were given a 30-day package of antiretroviral therapy and counseling and education. And subsequently, they were linked to clinical care. But for those participants in usual groups, they have to undergo 2 to 3 more clinic visits before starting antiretroviral therapy. So in this study, you can see very clearly that the rapid ART initiation, the home-based ART initiation, could increase the viral suppression, could decrease the disengagement from care. But when you look at the diagram at your right side, you could see that the rapid disengagement from care occurred in the very early days of participation in the study. So that's what we will see later on in many clinical trials, which indicate there are some barriers to tackle when we are going to implement the same-day ART initiation in countries regardless of the resources. So in 2017, WHO recommended same-day ART initiation for those diagnosed and ready to initiate ART. 83% of the 127 reporting countries implement the same-day ART, and about 2/3 of them had implemented such kind of program as of 2022. However, real-world observational data show discrepant results in terms of engagement in care with same-day ART versus usual care. So in this observational study consisting of more than 90,000 individuals at 380 public health facilities, the investigator found that those who initiate ART on the same day of HIV diagnosis had a higher attrition rate from care, although this group had a lower mortality. So on the left side of the panel, the left panel shows the rapid disengagement from care regardless the ART initiation on the same day or between 1 to 7 days or beyond 7 days. Again, in this recently published study involving almost 30,000 people living with HIV in 11 countries. In the IDEA cohort study, 64% of them started ART on the same day of HIV diagnosis. When we compare those who start ART on the same day with those who started ART at 1 to 7 days, 8 to 30 days, or beyond 30 days, the investigator also found that same-day group had a greater loss to follow-up. Again, you can see the greatest loss occurred immediately after ART initiation. But subsequently, you won't find any sort of statistical difference in terms of the attrition rate. These lines fell very parallel to each other. So why there are a discrepancy between clinical trials and observational study? Because it totally depends on the denominator they used in the comparison. For example, in your right side, if we start from 10 people, those 10 people were put on same-day ART, the denominator will be 10. So at the end of the day, 3 were lost to follow-up. So retention care will be 70%. But to the right panel, if you start from 10 individuals, but only 8 initiate antiretroviral therapy, so the denominator will be 8. So at the end of the day, there were 2 lost to follow-up. So at the end of the day, there were 6 remained in the study. So 6 out of 8 will be 75%. So it appears that in this observational study, 75% is greater than 70%. But if you count from the very beginning, if you include the 10 individuals as the denominator, so the rate will be 60%. So that's the reason why you observe discrepant results between clinical trials and this observational study. So I will move on to introduce what Taiwan has achieved over the past 2 decades. Taiwan implement several testing programs and treatment programs starting in 1997 when combination antiretroviral therapy were available. In 2016, Taiwan introduced Treat All and rapid ART initiation in 2018, along with several PrEP programs and testing programs. And in 2021, Taiwan introduced the point-of-care testing and confirmation of HIV infection. So if you have a HIV screening test, you can have the result in 20 to 30 minutes, followed by immunochromatographic HIV confirmation test, which takes about 20 minutes to 30 minutes. So within 1 to 2 hours, you can have a confirmation of HIV infection in the same visit. So you can put on the individuals antiretroviral therapy after providing support and counseling. So in this study by Taiwan CDC, you can find the black bar shows the HIV testing to confirmation has shortened from about 3 to 5 days to just 1 day. And the red bar indicating from the diagnosis, the confirmatory diagnosis of HIV infection to ART initiation, which has shortened from 37 days to less than 5 days. And the yellow bar indicate the percentage of those newly diagnosed with HIV infection who were put on antiviral therapy. The rate has been greater than 97%. And we recently conduct a study at 18 hospitals designated for HIV care to examine the interval between HIV testing and diagnosis to ART initiation. In this study, we have included about 1,600 individuals who were newly diagnosed with HIV infection between 2018 and 2022. You can see that 3/4 of those individuals were diagnosed in healthcare facilities, and the others were either in the public health services or the CBO or HIV self-testing. And the interval between the testing to engaging care was a range from 0 to 3 or 4 days. And subsequently, when they were linked to care, the interval between the HIV confirmation and ART initiation was as short as 2 days, and 99.2% of them were prolonged antiviral therapy. And the blue bar indicate the percentage of individuals who initiate ART on the same day of HIV diagnosis, which increased to almost 50% in 2021 and 2022. The yellow bar shows the percentage of individuals who were start ART between 1 to 7 days of HIV diagnosis. And the red bar indicate the individuals who start ART beyond 7 days. You can see the trends of changes. And even during the COVID-19, we still could start ART on the same day of HIV diagnosis. And we didn't see any greater loss or disengagement from care in those who start ART within 7 days of HIV diagnosis compared with those who were prolonged ART beyond 7 days. So in the past decade, we have implemented several programs, including Treat All, PrEP, rapid ART initiation, and in 2021, same-day ART initiation. We have observed significant declines of case number of newly diagnosed HIV infection over the past 5 years. The significant decline could be attributed to the introduction of single tablet regimen, which are very regimens which are very well tolerated and simple to take and effective. And also the programs implemented to expedite ART initiation. So to end the HIV epidemic, we need to improve or expand access to testing, treatment, and prevention, and to have efficient responses. And rapid ART initiation is a very important key component to end HIV epidemic. So WHO recommend ART initiation on the same day for those who are ready to start ART. But my question is really, who are ready? Is patient ready? We like to ask the patient to be ready, but we should ask ourselves, are healthcare providers ready to start ART on the same day or within 7 days? Is the government ready? Does the government have any commitment to improve the access to testing, to improve the access to ART, or to make those ART available, accessible, or affordable? And most important is to make ART or to make the state-of-art healthcare equitable. So I would like to use the conclusion, recommendation, and the implication made by Dr. Ford to end my talk. I think the same-day ART could really shorten or could reduce the pre-ART initiation attrition rate. And those studies showing that the discrepant results could be related to the denominator used in the studies. And I think we have seen a very significant attrition rate on the first day or the early stage of ART initiation. So we need to consider or develop any strategies to really reduce the risk of early attrition from care. Thank you.